At the outset, I would like to thank Ridhima for including me in this nice topic, and I thank the entire audience to be here such early in the morning. So my job is to talk about hypermetropia, and especially high hypermetropia, and how we can treat. I'm not going to detail of the definition of hypermetropia as in the latent hypermetropia, facultative, and all those things. But for the practical purpose, we divide hypermetropia depending upon the severity, whether it's a mild, whether it's a low hypermetropia, which is less than 2 diopter, or it's 2 to 5 diopter, which I would call moderate, and anything more than that is high hyperopia. Now, in high hyperopia, please remember that it may not be solo just refractive error. You may be dealing with a lot of other things. You may be dealing with a small eye. You may be dealing with a crowded chamber. You may be dealing with something posterior segment anomaly like pseudopapilloedema. The treatment options are plenty. We have the conventional non-surgical options and surgical options. But before we go, there's one more important thing which is most important in hyperopia is the refraction. This is probably the most important part and most neglected part in hyperopia management. Why? Well, because the hyperopic refraction is most of the time not very stable. You get a young individual who has actual refractive error of +5. With an accommodation reserve, what that person would have, you may be able to give a glass of +3, +4, +5, and in between anything. And you probably keep on checking and you will be able to get any refractive error, whatever you desire. The problem is you treat that refractive error, and after a while, when the accommodative reserve goes down, the rest of the refractive error starts coming out. And a lot of time we falsely label it as a regression in hyperopia, but we are really not sure about the dynamicity of the refraction in hyperopia. Hence, it's very important when you're dealing with hyperopia to do a good cycloplegic refraction. Cycloplegic refraction, by that I mean cycloplegic subjective acceptance. Very big misnomer in our country is cycloplegic refraction means cycloplegia and retinoscopy. That's not cycloplegic refraction. Cycloplegic refraction is cycloplegic subjective acceptance. If patient is not totally have not achieved total cycloplegia, make sure you give atropine and call back the patient again and do a proper refraction. But there is no alternative to not doing a good cycloplegic refraction followed by a post-mediatric test or PMT. There are very high probability these hyperopes may be amblyopic. In amblyopia, the other problem is that it's not switch off and switch on. It's not that you see 6/12 line clearly and next line you don't see at all. It's a graduation from one line to another line. Hence, patient may not give you a clear answer to that. And patient may say, yeah, I can see not much. And that's the time your optometrist or you may end up pushing extra refractive error or may end up giving something else. So in such kind of patient, it's very important to correlate all your subjective and objective findings of whatever way you are measuring the refractive error and try to give the correct refractive error. Also, you may have something like accommodative esotropia in such kind of patients. Now, in such patient, if you do not treat them adequately, you may end up having a persistent esotropia post-operatively. So, a person probably not having any squint, having hyperopia, my management may be a little different. I may end up having a little undercorrection, it's still fine. But somebody having an accommodative esotropia, I may have to be dot on target or rather have to give a complete refractive correction to that person. The conventional treatment like spectacles and contact lens, well, they're always there. But please remember, suddenly somebody comes to walks into your office and you try to give them high refractive error, especially high hyperopia, they're not going to accept it. They cannot relax their accommodation so fast in split of a second. You put a glass and they relax their accommodation. It does not happen like that. So it's quite possible you may end up giving some refractive error. Patient may accept that, and after a while probably you add on that refractive error and gradually it's like doing a slow fogging. You probably give a slow graduated subjective acceptance by increasing the power. And once it is stable, once we are sure, and then the refractive treatment start or the corrective treatment start. Starting with the laser refractive surgery, because laser refractive surgery is the commonest and easiest performed in hyperopia. But please remember, laser refractive surgery in hyperopia is not same as myopic laser refractive surgery. By saying laser refractive surgery, we open option of two things. We open option of surface treatment as well as the LASIK. The surface treatment for hyperopia started long time back in probably 1989 or so, but unfortunately the problem was the lot of regression seen, lot of scarring seen, and people were probably not so happy. The reason, reason is that hyperopic treatment is not as low as myopic treatment. So in normal myopia, you say per diopter you are ablating say 12 to 14 micron of cornea, depending upon your machine. But in hyperopia, it's much way more than that. So the hyperopic treatment is not just same peripheral treatment, because with the hyperopic treatment, what we are trying to achieve, we are trying to steepen the central cornea, which is quite unphysiological. With myopia, we are flattening the cornea. With hyperopia, we are ablating peripheral cornea so that to achieve a relative steepening in the center part, which is again quite unphysiological thing which we are accepting. And that's the reason why the hyperopic vision is not the best quality vision as compared to a myopic vision. The treatment is so large that you need to have a large diameter flap. It should be at least 9 millimeter flap. Otherwise, most of the time you will either end up ablating your hinge, or you may end up ablating outside your flap. Also, it's very important to make sure you check the pachymetry values on that region. Now, most of the time, if you are using a placidose-based device for your normal refractive workup and a central pachymetry, well, it will not work here. Please remember, a central pachymetry is not what you want. You want a peripheral pachymetry. So tell your optometrist to make sure you measure yourself the peripheral pachymetry in these cases. Also, these cases can have flat cornea, and you may end up having a free cap more often. So probably be prepared for that, and if possible, maybe femto can be a good option. Consider the angle kappa, and we know that high hyperopia can have large angle kappa, and hence your treatment may be different, treatment zone required may be different from the machine what it would understand. Machine would probably try to fire on the center of the pupil or visual axis, which may not be the sweet spot which you want to achieve with such high angle kappa. The trick there is, if you know about the angle kappa, you can probably deal with that by doing a manual decentration on machine, which is not very easy. But what people do is half of the angle kappa in millimeter they decentered. Again, it's a quite unscientific way to do that. But more scientific way to do it is doing a customized treatment. Such kind of cases you can do either topo-guided or wavefront-guided treatment, which definitely would help us in titrating it properly. Post-operatively, there are definitely high chances of regression, and post-op accommodative spasm can also be there. So tell these patients that you are not going to see next day 6x6 or like your myopic cousin who had undergone this surgery. Bring down their expectation to the realistic level, and then make sure post-operatively if patient is not seeing well, you might be dealing with accommodative spasm also. So be patient. You might have to give atropine eye drops to these patients, and sometimes it may be as much as 1 drop at night for 10 days and expect them to be back after probably a month or so. Outcome wise, the reported literature shows a quite good outcome, especially in low hyperopia. But when high hyperopia, we talk about plus or minus 1 diopter is like somewhere around 50% cases. So be prepared that if you have high hyperopia, you might have some undercorrection. Ridhima has already spoken about the Phakic IOLs. The Phakic IOLs of ICL and the ARTISAN. Again, one thing which we have to remember is anti-chamber depth. Shallow anterior chamber depth is quite common with the hyperopias. And when we talk about anterior chamber depth with Phakic IOLs, a lot of time we get fooled by the numbers. Now for ARTISAN, they say that you can implant this lens in 2.75 millimeter AC depth and you might be fine. Well, that's about myopia, not about the hyperopia. Hyperopic studies, if you go through, the maximum endothelial cell loss was seen in hyperopic iris fixated lenses. And in fact, they said that lifelong endothelial cell count measurement is mandatory in such kind of cases. Hence, your cutoff value rather than 2.75 should be 3 millimeter, what you normally follow. The special issue which we follow here comes in some cases, rare cases where you have like uniocular, one of my case, uniocular hyperopia. had vision, decent vision, like 6/12 vision best corrected, which is quite surprising because you might have dense amblyopia. But then in such kind of cases, we thought let's do an ICL and probably we'll do well because AC depth was good. Well, I was happy. Well, post-operatively, patient got 6/9 vision. And this does happen post-ICL that most of the time you get a better vision than what your spectacle corrected vision, and especially amblyopic cases. But the story doesn't end here. Patient, I was happy, but patient was not happy. Patient had consistently binocular diplopia because patient had a small hypertropia which I had missed. So 7 to 8 prism diopter small hypertropia which I had missed. And patient was not able to fuse. I did all possible thing with prism and whatever, ultimately ended up in explanting that lens. The lesson I learned that day was that such kind of cases, when you have asymmetric refractive error, make sure you do a good contact lens trial. Give the patient some time. Make sure you understand there is no binocular diplopia, especially in cases of squint, amblyopia, and anisometropia. Make sure you do this thing. The final option, if we have refractive error which is very high, well, very high refractive error, you can do something called BIOPTICS. Roberto Zaldivar described this terminology. Basically, what we do is we split the refractive error correction at two planes. One corneal plane by doing laser refractive surgery or any other sort of surgeries, and second inside by doing lens-based surgery. Now the lens-based surgery can also be phakic intraocular lenses, or it can be the refractive lens exchange like what Matthew described earlier. Now the planned bioptics can be in very high hyperopia where you might have to do a piggyback lens where you can split the treatment. You can do a refractive treatment on the surface by doing a LASIK or surface treatment, and inside you can do an intraocular lens. Or it can be unplanned, where especially in cases like say silicone oil or high hypermetropia where you're not sure about the refractive error or IOL power calculation. In such kind of cases, you can always top it up with a laser refractive surgery. The contraindication, well, contraindications are same as the contraindication for laser refractive surgery and phakic IOL or intraocular lens implantation. The preoperative workup is again same because we are essentially doing same treatment, but please make sure you do a good refraction and maybe a contact lens trial in such kind of cases. We can have multiple combinations here. Well, you can have phakic IOL and LASIK along with each other. You can have refractive lens exchange with LASIK, and you can have the cataract surgery, in which you can combine with LASIK. So there are endless combinations which you can achieve with phakic IOL as well as the refractive lens exchange. Finally, what you should decide is what works best in your hand. You may not have best experience with one particular technique, and you want to jump over to that particular technique may not be probably the best thing to do. Matthew has already taken care of the refractive lens exchange, hence I don't need to go into the detail, but probably I would say in very high hypermetropia, especially the patient is little senior age group reaching the presbyopic age group, I would definitely lean more towards the refractive lens exchange, but a younger age group, I would probably lean more towards phakic intraocular lens. So this is in nutshell about hyperopia and hyperopic treatment.